Epicondylitis actually is a misnomer. It's not a disorder of the epicondyle, and it's not an inflammatory condition. So the more appropriate terminology for that would be tendinosis or tendinopathy, and then there's these other terminologies listed here as well that you see in the literature every once in a while. So as we all know, whether we're therapists, trainers, or physicians, know that this is one of the most frustrating conditions to treat, and a treatment program for one person doesn't necessarily apply to another patient. Everybody responds differently. So it's frustrating for the patient, and it's frustrating for the providers. But lateral elbow tendinosis is tennis elbow, as you know, and it is the most common overuse disorder of the elbow. And the primary structure affected is ECRB. And in 50% of cases, the anterior edge of EDC is also involved, but ECRL and rarely ECU involvement in tennis elbow. And Fraser kind of alluded to this in some of his anatomy diagrams, but this article out of Japan, published in the Journal of Hand Surgery 2014, illustrates, here's ECRL, and this is ECRL reflected, showing ECRB deep. And then with EDC reflected, you see the tendinous portion of ECRB nicely here. And that is the only muscle tendon group at the elbow on the lateral side that is distinctly tendon at this level. The other muscles are blended with muscle fibers and tendon. And so that might be one of the reasons that ECRB is the primary structure affected in lateral epicondylitis. And the other point out of this article is that the anterior part of the capsule that's directly underneath ECRB is very thin and distinct, and a distinct structure, whereas you get posterior and distal, the capsule blends with the annular ligament and the supinator muscle, and so it's more supported. And then on the medial side, you have your golfer's elbow or medial elbow tendinosis, and the primary structures involved there are flexor carpi radialis and pronator teres. So there's very rare involvement of FCU, and cubital tunnel syndrome is seen in approximately 30% of cases associated with the medial epicondylitis. And then every once in a while, someone presents with both medial and lateral epicondylitis, and that's called country club elbow. Now, the epidemiology of lateral elbow tendinosis is often associated with repetitive motion, whether it's athletics or occupational. And again, the treatment can be very frustrating for all of us. And certainly therapy is an extremely important aspect of treatment for lateral epicondylitis. And all of these various therapy modalities have been used in various treatment protocols. I like to send my patients for ionophoresis as well as strength and conditioning. But all of these modalities can be considered, including TENX, which is ultrasonic debridement of the ECRB. And the non-surgical management of lateral epicondylitis includes a program of relative rest, not absence of all activities, but absence of abuse, and alteration of techniques or alteration of equipment. Counterforce bracing is used commonly. I like to use counterforce bracing during the day and wrist extension splints at night. And again, non-surgical management includes a rigorous rehab exercise program, including not only the elbow and forearm, but consider the back and the shoulder as part of the treatment program. Eccentric contraction is helpful as part of the conditioning program, and ankynia strengthening and ulnohumeral tracking can be used. And then non-surgical management includes careful consideration of injection, steroid. Steroids can be helpful in the short term, but there's a lot of studies out there that show that they may not help in the long term, and the recurrence rate is quite high. This study here compared corticosteroid injections with ionophoresis with corticosteroid for lateral epicondylitis, and they randomized 82 patients and split the group into dexamethasone via ionophoresis, dexamethasone injection, and triamcinolone injection. And the ionophoresis group statistically showed more improvement in grip strength and more likely to return to work without restrictions. This study here randomized patients into steroid injection and placebo injection, and then steroid injection and placebo injection with physical therapy. And they assessed outcomes at 1 year with a global rating of change scores from the spectrum of complete recovery to much worse, and also analyzed the 1 year recurrence rate. And the interesting part of this study is the steroids had lower complete recovery or substantial improvement percentages than placebo. 83% recurrence with, or not recurrence, complete recovery with steroid. And the placebo was 96%, and then also a higher recurrence rate with the steroid, 54% compared to 12%. And the physical therapy, this is doesn't mean the physical therapy is not helpful, but in this particular study, that did not alter the percentages that we just quoted. And then this is a study that we did here at the University of Colorado, randomizing injection of saline, autologous blood, and corticosteroid. And outcome measurements included DASH scores, and VAS scores were taken pre-injection at 2 weeks, 2 months, and 6 months. And the interesting part of this study is that there was no significant difference at 2 and 6 months for all three groups. And this is another study that one of our fellows did, and it was published last year, analyzing the depression and anxiety among patients with atraumatic lateral epicondylitis and ulnar-sided wrist pain. And we looked at both diagnoses, but I've only included the stats on lateral epicondylitis for this talk. But patients with a history of depression reported pain scores 1.2 average higher than patients without a history. And the reported rate of any mood disorder in the US general population is 9.5%. In this study, 34% of patients with lateral epicondylitis had medical record documentation of depression or anxiety or both. So that's almost 4 times higher in this diagnosis. And this correlates with a paper that David Ring out of Boston published a few years ago about coexisting mood disorder negatively impacts surgical outcomes and perceptions of pain and disability with a variety of upper extremity conditions. Surgery is very rarely indicated, in my opinion, for lateral epicondylitis, but it can be done open or arthroscopic or percutaneous release. And the indications for surgery is obviously failure of conservative treatment, including all the things we just mentioned, and monitoring over an extended period of time. Calcific tendinitis can be a contributing factor to take someone to surgery, or bony exostosis. But most people get better with conservative management. And I tell my patients that they're going to be dealing with symptoms for an extended period of time, but at some point, this is a self-limited problem, and most people get rid of their symptoms, although it may take a while, several months, or even a couple of years. And most people that do end up having surgery get a decent result. And this is just an interesting addition, a different way to consider treating lateral epicondylitis surgically. And Lee Dellon, who has a national reputation for nerve work and research, published this paper in the journal Hand Surgery about taking the posterior branch of the humeral, lateral humeral condyle is innervated by this posterior branch of the posterior cutaneous nerve, and this vessel loop is around that branch, and just snipping it and denervating the lateral humeral condyle. So just an interesting way to look at treatment of this condition. And there are the stats out of that study: 30 elbows and 26 patients. And you can see the VAS scores improved, and 80% got good to excellent results, and grip strengths improved. There were 5 failures in there, and 4 out of 5 had radial tunnel syndrome. And then just very quickly on the medial side, it's not nearly as common as lateral epicondylitis, but it is the most common cause of medial elbow pain. Peak incidence in the 3rd to 5th decade, 2-to-1 male to female ratio, and more common on the dominant side, and associated with ulnar neuropathy in 50% of cases. Fraser alluded to this too, but certainly in the evaluation of both lateral and medial epicondylitis, you need to consider more proximal pathology, including cervical radiculopathy and TOS, shoulder level problems, and then snapping medial head of triceps, and subluxation of the ulnar nerve, and the triceps tendinosis, and MCL insufficiency can all be on the differential diagnosis. The treatment basically is the same. I find medial epicondylitis easier to treat. It seems to be more predictable, and patients respond to conservative treatment for the most part. And again, ones that go to surgery are usually successful, but in my hands, it's rare to take a medial or a lateral epicondylitis to surgery. Thanks.